2006, when I became much more active in the Lane County Medical Society. I originally rose to the presidency of one of the healthier county medical societies in the state. And so these are all things that, and my presence here on the board, too, is a labor without a lot of tangible benefits, certainly. I could make a lot more money practicing urology down in Eugene, but I do it because I believe in the integrity of our profession, as do you. And I see physicians policing one another as a crucial part of medical malpractice reform. And this is me putting my time and efforts where my beliefs truly are. And I hope that you share my view that this board is a meaningful part of that. And we certainly welcome your feedback moving forward in the governor's plans for malpractice reform. Just a few final comments. Some of the matters that you brought to our attention actually are already being paid attention to, thanks to the very hard work of Ms. Haley and Dr. Thaler. When we finish an investigative committee meeting, the staff here at the board will review the findings of the committee, compare it to findings in the past exactly for the matter of consistency. Are the disciplinary recommendations of my committee consistent with similar cases that have been brought before the board before? So, thanks to Ms. Haley, those things are being looked at. Anecdotal information. Now, granted, anecdotes have their limits, but the feedback I have received from my colleagues in Lane County has frankly been polar opposite to what yours has been, and I hope you can accept that for perhaps the limited value that it is. But I have breakfast in the physician's dining room, where it's widely known that I'm a member of the IAD, the equivalent thereof for physicians, and I have conversations about things I'm permitted to talk about, and share de-identified stories of redemption, which is the single most gratifying thing that this board does. The single most gratifying thing. Yes, we take seriously our job of protecting the public, but a physician is rehabilitated, and we see those stories. It makes one of those stories per meeting makes our day. I've heard stories from some of my colleagues, Dr. Rugani, a pulmonologist, for example, that prior board interactions were very malignant and imperious, and that those have trended for the better. So I see this dialogue that you're proposing as very, very important, and I thank you for bringing the concerns, and hope that you accept that we'll greet them seriously.
Thank you.
Thank you.
Dr. Koval?
I just wanted to thank the Senator for coming. I really appreciate the fact that in the state of Oregon we have physicians who are in our state legislature. I think that's wonderful. I think it's wonderful that we can get feedback from the legislature through the eyes of physicians, too. I think it's so important. We all recognize that we work for the people of the state of Oregon to provide them a safe and healthy environment. And, of course, many times when we're acting against a licensee, we're acting as a result of a complaint filed by a citizen of the state of Oregon. So we have to respect that complaint and make sure we adjudicate it. But thank you, Senator, for reminding us the importance of transparency and process to ensure the rights to the licensee that we're investigating, and that we ensure that we do it in a fair way. The senators have talked about the issue of opioids, and we've referred to it too. And it's easy to have it come to your attention when the Wall Street Journal last weekend talked about the prescription for addiction, and the blame fell on the prescribers and the pharmaceutical industry. And today's Oregonian cites another article on page 2. Again, this is a sting operation in New York where prescription narcotics were confiscated, not just from drug dealers, but from people who are financial advisors and mothers who were cleaning out their medicine cabinets and selling the drugs. I think this speaks to Ralph's comment earlier about the economics of the situation and how that's impacted the way medicine's practiced. Sometimes patients seeking drugs to be able to sell in the street to earn money.
I don't want to be rude, Dr. Koval, but can I interrupt you for just 1 second?
Certainly.
In my personal experience, the stories that I've heard, and I would venture to guess the same holds true for Senator Bates, the opiates are actually the least of our worries. Those are the cases that we think when we hear complaints about them, in my personal experience, those are the ones that we are least likely to believe. All right, the people tell us what they've been doing, and they tell us the actions board's been taking, and we say good, or I say good most of the time. I don't say that out loud to them. I say, understand your concern. Right? We all know this when our patients tell us something unreasonable. So my personal sense is that the board has been put in a very, very difficult position, that everybody's between a rock and a hard place. On the one hand, we're not treating pain enough, and on the other hand, we're overprescribing opiates. Well, gosh, we're darned if we do and we're darned if we don't. I'm personally much less concerned about the licensees with whom you're having interactions about appropriate prescribing of opioids than around cases that don't involve that. And we're also not particularly concerned about impaired physicians, because overall our sense is that those are being handled appropriately. I agree that we've got problems. The health professionals program changes were not exactly what we all might have wanted, and we need to revisit that at some point. But I don't mean to interrupt you, and I do want you to keep going, but I just want to be clear that that's lower on my personal worry list, to be honest.
I was actually, for a personal reason, taking the opportunity to voice this because the number of deaths of Oregonians from opioids has exceeded that from traffic accidents. And it's a major public crisis, and I wanted to make sure the legislature knows that full well, and I'm sure they do.
We implemented the statewide database in 2011 because we thought that was so important.
But it speaks also to the issue of transparency, because as others have alluded, we need to know and understand the nature of the cases that we are adjudicating incorrectly. If it's not opioids, if it's not substance abuse, what is it and how can we fix it? Because we need to know specifics for transparency purposes.
And this is supposed to be an open dialogue, so just to show you that no two senators can agree on anything. I agree that we're not worried about the board's function as far as impaired physicians are concerned. You guys do a great job in that. In fact, it was a model for other boards. When the law was changed, other boards didn't have the financial resources to really do what they should have been doing and have had to ask to raise their fees to do it. This board didn't have to have an increase in fees because you had the program going already, and frankly, I wish you were exempt from the programs. I think you were doing a better job before than you can do now, but that's something different. So I'm not concerned. They're doing a great job. It's some of the hardest things I ever dealt with as chief of medicine was physicians who had narcotic problems or alcohol problems or personality disorders. So please take that off the table. That is not the issue here. I'm going to disagree with you a little bit, okay? The opioid thing is a lot bigger, I think, than we realize. And Dr. Koval, I think you're absolutely correct. I saw the same numbers for the nation and the state that automobile accidents are going down, and they crisscross this year for drug overdoses, both, and these are unintentional drug overdoses. These are accidental drug overdoses. And, it's a serious problem, and it is not. I believe it is not clear in the minds of prescribing physicians what exactly is required from them in dealing with these patients. And I'll give myself as an example. I attended a 2-hour or 3-hour seminar on it 2 weeks ago at the local level, and just spent 5 days in a national level. And it is, and you hear from all different speakers, and you get a little different flavor each time for these things. It's not clear. I would love to have a board that people would feel comfortable, prescribers would feel comfortable calling up the board and saying, what is the actual requirements for documentation for me to write opioids? We, in our practice, decided because of this issue that we are not going to do it for people under 65 or people who are not cancer patients. And we probably, in our whole practice of thousands of patients, have 20 or 30 patients. And Dr. White, these are the ones that I struggle with. They'll put 3 patients in 3 different rooms, and my MA, as I skip one room, will say, Mrs. Jones was next, but I don't want to go in there because she wants her narcotics, right? And those of you who practice in this field will probably shake your head up and down because you all got them in your practice. But that's an example to me of how the board would hopefully be able to function a little bit differently in the future, that a physician would feel comfortable calling up and saying, my biggest problem is how to deal with these 20 or 30 patients in my practice that are on opioids. They're in every 3 months. What do I do for documentation? Should I send them all to pain centers? Well, the pain centers can't take them all. I can't get them off. If I don't give them to them, they're going to get in the street anyway. They're going to have the methadone clinic. It's a mess. It's a huge mess. And if we had a board in which people felt they could call and share that kind of information with you, I think that would be a huge step forward. Because I don't think right now most physicians would be comfortable calling up and saying, I don't know if I'm doing the right thing or not with these opioid patients. What are your guidelines? Can you help me with this? I think they'd be scared to call you. And that might be just one example. There might be others. Should I be doing Botox injections when I never did a residency for it because I need to make some money? Okay? Those kind of questions I don't think you ever get up here, or very rarely would get, because people are afraid that opens them up to investigation and scrutiny.
Doctor,
That's a cultural change, both on the board's part and the part of the people that you're trying to help, the practitioners.
well, Doctor, we do get those calls. I get them, and our board members get them. Not so much the board members, but the staff gets them. And we try to answer those questions, just like if somebody's calling about any other medical problem. And they're not easy answers. Yesterday at the noon board meeting, we had the chief health officer of Jackson County, where there's a bigger problem than anywhere else in the state with deaths, come and talk about a program for physicians that they've created down there, where the physicians themselves have come up with certain criteria. That is a website that's available that any physician in the state can go to, can learn about the different ways that they're trying as physicians to control the problem. So we're trying to find those answers. We're not saying you have to do this, but we're trying to get the physicians out there who are working on the problem, including here in the Tri-County area, where there's going to be, I think very shortly, a statement about what are the standards that are expected within the Tri-County area. We're trying to gather that information so that it can be answered, because it's as tough a problem as if we didn't know anything about diabetes. How do you treat diabetes? That's the kind of thing that we're struggling with, but we're trying to listen to physicians. And I attended a conference at the OMA last week, which was excellent, where the two experts there said there's a program that you can have within 5 minutes of walking in the room, the answers to those 10 questions that the patient can fill out, so that you can follow and check and have the answers before you even see the patient about those 10 questions. So I think a lot of people are trying to deal with it, and we don't absolutely have the answer yet, but people do call us about those questions. And I don't think they're afraid that they're going to get reported because they call.
Thank you. You know I'm from Jackson County, right?
So
I know the program. I know.
You know the program. So it's a
As well as
great,
that.
I think all the board members here really appreciated hearing that talk, and I heard it at the OMA, and I heard it as part of the drug conference about 2 weeks ago that they've done.
I would just offer that I know for a fact physicians are not following, some physicians are not following that, and are not going to be willing, I'll just leave it that way. I'm not willing to call the board. They should. They should. Okay? They should get on track. But I'm using that as an example. Okay? Thank you for your
It's a good
I
example.
think this
comments.
does bring up a really interesting point that I suspect we've all encountered, which is that the people who need help the most are the ones who are the least likely to seek it out, right? Those of us who spend a lot of time thinking about how we can be the best physicians possible are the ones who are the most likely to pick up the phone and call. And the people who are struggling, whether it's because they're making poor choices because of economic reasons, as Dr. Yates brought up, whether it's because they were brought up in a different era of medicine and they've held on to beliefs and haven't been comfortable with the new education they've gotten, whether they're arrogant, which we certainly see, whatever the reason, it's a problem with education, ongoing education in medicine, period, right? I mean, I still know doctors who do pap smears on 70-year-old women who don't have a cervix. That's not really necessary, folks. And we can't get through to people sometimes. So one of the questions that we're going to have to think about on an ongoing basis is, what is the right role for the medical board in terms of helping physicians of every stripe, and I'm including the podiatrists and the acupuncturists and the physician assistants who work with us, in staying up to date. We have continuing education requirements, but we don't require that people prove anything. If they've actually learned anything or made changes in their practice, I think that would be almost impossible to do. But we will have new opportunities, and we do need to be thinking about some proactive ways in the long term that we can have interactions that help keep physicians really up to date.
And that's, I think that stuff is clearly underway with regard to maintenance of certification, board certification, and even some degree something called maintenance of licensure, which we don't have a lot of time to get into. But that theme is one of the most significant, or if not prevailing, themes in healthcare reform and ensuring ongoing competency for everyone, that they're going through the educational activities that are meaningful, that actually do what we want them to do, and then that we're seeing the results of those educational activities in a positive light for quality. I think we're coming down to the last couple of minutes, and Dr. Mastrangelo had his hand up. You want to make a couple of comments?
Well, first of all, senators and colleagues, thank you for coming today. Most of the points I was going to make have already been made. But there are a couple of things I'd like to just discuss with you. First of all, I think you're here for a reason. You've identified a problem, and it's good for us to know that problem. And I'm glad that you're not on the defensive anymore. That this is something that we can work together on. I've been reminded in the community of the negative image of the board. I have colleagues ask me why would you want to be on the medical board? Are they paying you to do that? And a lot don't understand why I would want to be on the medical board. There's misunderstandings regarding the peer program, and there are physicians who've gone through the program in the past who are upset that the program's not there anymore and think that the Oregon Medical Board did away with the program, or that we had the power to do away with the program, and so there's resentment because of that. There's some resentment, I think, because I think some of our very egregious physicians that we evaluate who've done things that are almost unthinkable are sometimes in denial about them. So I think you're going to hear some complaints, and it sounds like you've done a good job of filtering those based on how you describe things. Our medical director gets 800 to 1,000 complaints a year. Is that a reasonable number? And that's filtered down to roughly 200 or so that come before the investigative committee. So there's a vetting process or a filtering process that takes place here as well to protect physicians, because all someone has to do is go on the internet and bring up the site and type in a complaint, and there's a complaint against physicians. I think one of the things you need to understand is that physicians, and you did explain this, you said that you know that they're only going to tell you one side of it, and it's their side of it, and they're upset. But I would, it's really interesting, and I would encourage you to follow through on what you were discussing with Dr. Yates in terms of invite that physician to come to the board with you and to review everything so you can see the whole case next time you get a complaint like that. Because I had a personal friend, colleague, who told me for several years how poorly they were treated before the board, and it wasn't until I came up here to the board that I realized that he was just lying outright to me about the facts of the case. So it's that's something to be taken into consideration. The other recent thing is that I think that it's hitting harder now with the economy is the stakes are a lot higher, because there's more reportability now. There's more cooperation between states. There's more international cooperation. So something that starts as a 3-month suspension at your hospital can trickle down to a board investigation, can mean that when you go to renew with Blue Cross Blue Shield and ODS, that they say, finish up with the board, and then we'll talk about renewing you on our panel. So all of a sudden, they drop off the panels for 2 years, and they're overextended on their houses because of the economy and everything. So things are more tenuous for physicians, and it's very real that physicians who come before the board can end up losing their houses. It's stressful on their families. They lose their families, and in some cases it pushes them to do other things that they wouldn't otherwise do. And we understand the impact that has on physicians and the stress that it has on physicians. So we try to be very careful about who we decide to investigate and how we push those investigations. And if we need a way to identify if we're investigating someone and it's causing undue stress on them, and maybe they're being investigated in error, then if you have a way to identify that, it'd be useful to us. It'd also be nice to figure out ways to have better outreach to physicians. We've had several cases since I've been on the board where we identified that the complaints against the physician were politically motivated, and we've identified that and
got in the middle of those a few times.
And tried to work very quickly to resolve those. Exactly. The board is looking at things that they can do, like a certificate for retiring physicians with clean records who've done service to the board. Dr. Yates presented one to a retiring physician just last month or several months ago, and got a very positive response from that. Ms. Haley has done outreach with students at OHSU to talk to them about prescribing issues, about boundary issues, about the types of issues they need to know about that would keep them from ending up in front of the board. The previous medical director, and I'm sure Dr. Thaler will as well, has gone out to medical societies and given similar talks to try to educate colleagues about the board and what the board's role is. So if there are positive things like that we can do that you know of, additional ones, then we're really looking forward to working with you. The other thing the board does is the board tries to get local consultants. So it's not the board in the ivory tower bringing down the adjudication. It's we're bringing in consultants and they're not the consultants necessarily from OHSU or from a disparate practice. If it's a community physician and it's a medical issue, then we try to bring in a community physician from a similar type community in order to get that perspective, so that the standard of care in the community is taken into consideration.
I've served as one of those people.
Oh, that's great. So you might get a certificate when you retire.
There was a complaint filed against me when I was a resident, but fortunately in that case the board dealt with it very appropriately.
Well, thank you very much for coming, and we're very much looking forward to working with you.
Thank you. Can I ask Taylor a question?
Sure.
I'm trying to keep notes here. Didn't get it right here. 1,000 complaints a year, roughly.
In that range.
In that range at least.
And then there's a screening process.
Right.
Sometimes people complain about stuff that isn't.
Yeah, I disgruntled patients are out there too.
Lots of them.
A little surprised by the volume, but it's 4 million people in the state almost, and 7,000 physicians, I suppose. How many is it now?
14,000.
14,000.
There's
Wow.
14,000 licensees, which includes
I
CAs.
think actively practicing around 7,000 or 8,000.
Probably a good guess.
Actively practicing.
Yeah.
I'll go back to my chief of medicine days. I had about 500 physicians that I worked with, and it was always the same 3, 4, or 5. I had all my problems. Okay, I know it's shocking that 3, 4, 5% is the whole problem. Do you see that in these 1,000 complaints, or is it pretty just spread across? Is there any pattern here?
Well,
this goes back to some kind of objective data.
I think the complaints that the board ends up opening on are unfortunately sometimes repeat problems.
Okay.
Of the 1,000, it's just a scattering.
It is scattered across the landscape.
That's one of the factors we'll look at when we open a case is what is the past history. You know, and if a person has had 3 complaints in the same area, then when that 4th complaint comes in, we're going to take a look probably because there may be an issue. The trend does point to an issue sometimes.
And we're talking about, again, not impaired physicians, but just...
Correct.
Right.
Medical,
Thank you.
And sometimes there are themes of complaints that change from year to year, and it's interesting to try to predict those patterns, and it may be related to economics, access to narcotics, some domestic violence, and violence in the workplace is a strange pattern, and we don't really fully understand why we see these spikes, but that's what we see. Mr. Turner, do you want to make a couple of comments?
Sure, thank you. Senator Bates, Senator Hayward, thank you for being here. I've been on the OMB since May of this year. I'm one of the other public members. Mr. Kopetsky and I are the public members. I'm the executive director of Emmanuel Medical Center Foundation. I work for Legacy Health. I also used to serve on the DO board in California about 10 years ago as the public member. So it's interesting to see how this board differs from California. In a lot of ways, they don't. But as a public member, Mr. Kopetsky and I, we get the cases that are kind of the juicier cases sometimes. And so, if you will. And one thing that's really important I want to start with is, a lot of folks forget, we talk about Olympians, we talk about athletes. The public expects doctors to bat 1,000. And I try to remind people that that is not a reasonable or a realistic expectation. Everybody's a human being. Everybody brings different experiences. Sometimes they perform perfectly and sometimes not quite, and sometimes not even close. But that's part of being a human being. And so I try to bring that perspective because in my job, too, I don't bat 1,000. I try to bat 300. And I also try to come here as a fundraiser. My job is to monetize patient gratitude. So I want happy doctors. I want happy nurses. I want professional behavior. I want happy patients walking out the door or I wouldn't be employed. So, part of happy doctors and happy providers is fair and just probes into the work they do. And so I take that very seriously. Everybody here does as well. The staff here is very diligent, very ethical, very hardworking. I get all my questions answered. I have a lot of questions. And one thing that I bring to this board, and my fellow members would say this already, is I do try to look at the nexus, basically personal behavior versus professional behavior, how that all ties together. And where are the limits of our enforcement capabilities, making sure that we're not overstepping any bounds and that we're not, stepping into areas where maybe some other agency or some other, body should look at those areas more closely. That said, we are talking about physicians here and they're held to a high standard and the public expects them to behave a certain way. So I do want to say that, just in closing, I've been very impressed in my time here this year with the very close look we take at some of these large malpractice settlements. And in closed session, we see sometimes these $3 and $4 million, $5 million settlements, and as a layperson, I'm thinking, wow, they must have done something pretty awful. My fellow members that are physicians said, actually, not really. It's just that there's this whole system in place that says, settle, settle, settle. We don't want to go before a jury. So very, very, on a regular basis, every meeting, we have these cases where you might have a situation where there's even a wrong site surgery, where the board decides they did everything they could once it happened. They were honest, they were ethical, they were professional, they fixed the problem, and we don't take action. In other words, they've done what they're supposed to do as a human being in that situation, referring to my comment about batting 1,000. So I find that, I'm here to look at patterns. I'm not interested as much. There are isolated errors that are very egregious, but I'm more interested in patterns of bad behavior, and I think most members are. We try to find, people that are practicing in a way that's dangerous to public safety on a regular basis. And I definitely am interested in those people more than the others. And those with personal issues, we definitely have lengthy conversations about ways that they can, find some resources and some services to fix those things. And we remind those doctors, you're running a team here and you're leading a practice. You have people that depend on you for their incomes, and you have a family that depends on you and a community that depends on you. So I'm very fair-minded and I'm very open-minded. I found that my fellow members are as well, and I really don't come here to try to be punitive or scare anybody. But we do see some really serious cases at times that literally I've told Ms. Haley I want to go home and take a shower, after some of these hearings that we've had.
the pedophile pediatrician, for example. So, we see it all. So with that said, I just want to thank you very much for being here, and I'm happy to have coffee with you, to come to Salem to talk to you further and discuss, as Mr. Kopetsky, what our perspective as lay people here that are consumers of healthcare.
Thanks.
I think we're starting to wind down time-wise, but please...
Just real quickly, first I want to thank you all for taking your time to talk to us. You're all busy physicians like I am, too. I still have a full practice, and at the end of that 80 or 90-hour week, I'm pretty burned out. I'm in a little better shape this week because I was at CME all week, so I feel a little better. It's going to change on Monday morning, but I really appreciate the huge effort and time you put in this, and the exhausting efforts of looking at these cases and working through them and doing the very best job you can. I don't want you to go away thinking we don't recognize and appreciate that and honor it. Okay. Whenever I have this kind of a meeting, though, one of the things I've learned to do is, and it seems to help out, is what are the next steps? And I heard three. I think I heard three things here, and I want to make sure we all agree on those, or at least that's kind of the direction we're going. One is that the peer program needs to be reinstituted as quickly as possible. I've even in the back of my brain, because I'm a Ways and Means guy, thinking of ways how that could be supported financially through the state.
Exactly
and frankly, through
I'm a Ways and Means person too.
I actually did the numbers here. We have about 7,000 or 8,000 practitioners. I'm thinking how much we charge on the license, which is a pittance, and if we put that into a peer program, what kind of a program we could have. So I always do the back envelope stuff, and it's pretty close sometimes. I can't make a computer work anyway. Number two, you would like to have us bring some individual cases to you if we find something we think really needs to be discussed, so we can understand better, and maybe it would be helpful to you, maybe it wouldn't be. We may walk out of here feeling kind of embarrassed after we brought it to you, but that's a good thing for us too to learn. So I know of two cases that we would ask the individuals if they allow us to do that or not, and we would come back to you with that. Okay?
Yeah.
Okay.
Keep going.
The third thing is some way of getting the word out to our practitioners. This board is open to helping you with issues in your practice you might feel uncomfortable about. You're already getting calls in, but I would offer that for the most part, there's a lot more out there that could call you. And if you said you got 5,000 calls the next year with an open program, I'd feel like, wow, that's great. Okay, but I think most practitioners, but that's the last place they call. I like to see it be the first place they call. So that's kind of a change in culture, and maybe through the newsletter, instead of all of us doing what the names, anybody I know, the first thing I'd see in that page is the board is especially concerned about problem A that might be existing in your practice. Please call us. We'll give you the guidelines and help, and with you in any way we can to help patients be safe and to help you be safe. Okay, that'd be number one.
To help you is not an oxymoron.
Yeah, so that kind of stuff. So those are the three things I heard. I don't know if that resonates with people on the board or not.
I got a fourth when you're done.
No, I'll put number 4 down there.
I agree with everything that Alan said, and the only thing that I would add is that it would be really helpful from my perspective to sit down, and I don't know, Ms. Haley and I have been crossing wires a lot on appointments, and I'm very sorry we talked about this ahead of time, but I don't know whether that's a conversation with just us or whether it's with you, Dr. Williamson, or you, Dr. Thaler, about what the process really does look like and how people are supposed to understand the process and what your standards for investigators are about how they interact with people, because I do think that that's potentially a legitimate concern that we just need to clarify with people. So if we could figure out who the right people are to have at the table and plan a couple of meetings so that we can sit down and we can get better informed, and we can understand how we can help our colleagues be better informed about the process and make sure that there is a consistency of approach in the investigation that does allow for due process, that will be also very helpful and reassuring to people as well. Because I think that there's a sense of some black box stuff, and that's not what any of us want, right? That's when people get afraid, when they don't understand what's going on. So to minimize fear and promote this environment of, I'm from the medical board and I'm here to help you, which is really true, as opposed to, I'm from the medical board, hide your children and lock up the valuables. We need to demystify the process.
Absolutely.
And not violate people's discretion, not do anything like that, but privacy, but demystify the process. So figuring out who the right people are to have these ongoing conversations, we can work together offline to do that. But I think we're both very willing and eager to be part of that process with you.
Great. I had to come up with 4 action items. They're exactly the ones you've outlined, and especially developing lines of communication to hear back from you, whether it is in terms of specifics or broad themes about things that you think that the medical board should look at doing. We need to do that. But we will arrange a meeting or 2, and if you're willing to do this, we'd love the opportunity to sit down and have a conversation regarding the anatomy of a complaint and what to expect and how it goes through and how it might vary depending on the specific issue that's brought to the board at hand. And we do want to demystify the black box because we are very, very interested in shaking the theme that we were a Gestapo-like agency. That is not what we want to be. And I have to say, part of my satisfaction about being part of this group is that I share this theme with other members that we want to turn ourselves into and create as much of a positive light as we can, understanding that we have a difficult mission ahead. And I also want to take a minute to reflect and acknowledge the excellent work that Ms. Haley has done as director for many years, and our staff. We've had conversations about things that we can work on to improve, but on the same token, it is in the light that they've done a fantastic job and a really wonderful organization, and it's a wonderful opportunity to be part of this group. And the last comment that I think that I'd like to say is that this is incredibly helpful to us. All of us as a board want to hear what you have to say, and we do not want to take a defensive posture because we're a bright enough team to recognize that we cannot improve again without having the kind of feedback that you've offered us today. It's hugely valuable, and we want to hear more. And thank you for taking valuable time out of your schedules to share that with us. And we will follow forward with a dialogue and hopefully see some extra support from our legislature in an effort to restart the peer program. And we're happy to share some ideas with you on how that might go down in a way that might maintain some budget neutrality. So there's maybe some creative ways to make this happen that can bring it to reality and make it easier for physicians to get help when those situations come up.
Great.
You're wonderful. Thanks for doing this.
Well, thank you all for inviting us to come and talk with you and for your openness to continuing and starting and continuing the dialogue.
We will.
Thank you very much.
Thank you.
Thank you.
You missed the Thai lunch.
Haley tried to convince me to eat before I came, but I figured that talking to you with my mouth full.
If you do have the time,
And if I knew there was free lunch, I wouldn't have eaten before I came.
the invitation to join us for an investigative committee is on the table any time. If that time does come up and you're really interested in that.
In 1 hour.
I'd very much like to do that. It would be very helpful. I mean, I served as co-chair of the Institute for HSU for 4 years, and I was on the executive committees of the Department of Family Medicine and the Department of Obstetrics and Gynecology at Southwest Washington Medical Center for 5 years for my first 5 years. So I have similar kinds of experiences, and I would very much value that opportunity. So we'll work on getting that set up. At some point.
We each of us do this similar administrative roles within Providence and chair Department of Surgery and Vision Regional and all the same things. We'll have a lot of mutual things to talk